Dr. Jennifer is going to talk about tailoring and omitting radiation therapy in certain patient situations. Please, Dr. Jennifer, the floor is yours.
Thank you so much. And it's just such a pleasure to be invited, and I'm so appreciative. And again, as Dr. Gulshan said, so sorry that we couldn't be in person, but hopefully in future years. And also thank you for putting us in the afternoon. Can you see my slides okay?
Yes, okay.
Yes, okay, great, thank you. These are my disclosures. So this is old data from the EBCTCG showing that radiation can not only decrease the chance of recurrence in the breast, but it also improves overall survival. But if you look more carefully at the numbers, you see that the recurrence rates are nowhere near what we're seeing in modern times with modern studies. And even though this did show a benefit to radiation, as we all know, physicians who treat breast cancer, radiation is inconvenient, it's costly, and it also has potential toxicity. It impacts the cosmetic results of the breast. It has potential pulmonary and cardiac toxicity, although we try very hard to minimize that. And there's a very, very small risk of a second malignancy. So there have been multiple trials over the last 30 years that have tried to figure out who can omit radiation, and is it really necessary in everybody, despite the benefit shown by the Breast Cancer Collaborative Trialist Group. And I'll review some of these early trials. This is probably the most famous one. This is by the NSABP, and they looked at cancers smaller than a centimeter and randomized those patients to radiation alone, tamoxifen alone, or radiation plus tamoxifen. And I think that this trial really spoke to the pattern of thinking at that time, where we took in the smallest cancers, those less than a centimeter, and asked whether we could omit radiation. And I'll show you in a few minutes how I think our thinking has evolved to try and understand the biology of the cancer and re-ask the question of omitting radiation, I think a little bit more attuned to the biology. And this trial showed that no, you can't omit radiation in these smaller cancers. So the chance of recurrence with tamoxifen alone was 17% at 8 years compared to only 3% with tamoxifen and radiation. We did a small prospective trial in the Boston area hospitals, where we also really thought anatomically rather than biologically. So patients had to have tumors smaller than 2 centimeters, and they had to have a 1 centimeter surgical margin, but almost all of them had a completely negative re-excision. And we thought that these were quite favorable cancers. The median age was 66. Most were mammographically detected, and median size was only 9 millimeters. But despite that, the trial was closed prematurely due to a 2.8% per year local recurrence rate, so 23%, which is really felt to be unacceptably high. And we also have a randomized trial from Finland, also trying to answer the same question. So again, patients with T1 or T1 N0 node negative disease, they did have to have grade 1 or 2 tumors, and again, widely negative margins. And you can see that there was a substantial benefit to radiation therapy with an 18% chance of local recurrence with a median follow-up of 80 months, and about half that in patients who did receive radiation. Now, we also have a literature looking at whether we can substitute hormonal therapy for radiation. And probably the most well-known study looking at this is from Kevin Hughes at Mass General, where he randomized patients to tamoxifen alone or tamoxifen with radiation, and these were all women over 70. And what he found was that radiation lowered the chance of recurrence in the breast by about 8 percentage points at 10 years. But this did, in this older population, this did not translate into a difference in overall survival. And a very similar study from Ian Kunkler in the UK, but this time in women over 65. Eligible patients had tumors smaller than 3 centimeters, but were also node negative. He did include patients with high-grade disease and LVI, although, and that would have been really interesting to see how those patients did without radiation, but unfortunately, this was a very, very small minority with either high-grade or lymphovascular invasion. So I think really too small to draw any meaningful conclusions from that group. And again, extremely similar results, very consistent with the CLGB data, that at 10 years, the risk of recurrence was about 10% compared to 1% in those patients receiving radiation. So this might be a reasonable option for older patients who have a limited life expectancy or who prefer to omit radiation, knowing that it didn't impact life expectancy, but there was an improvement with radiation. So why can't we uniformly apply the meta-analysis to 2021? So why do we not tell patients anymore that there is necessarily a survival benefit and that radiation is standard? Why do we have to relook at this? I think the number one reason is that systemic therapy is more effective and not only improves distant metastasis, as has been well studied, but also local control. And we've seen this again and again throughout multiple studies. This is the early breast cancer trialist collaborative group in a meta-analysis looking at the role of chemotherapy on local control. And you can see that the hazard for local recurrence was decreased by about 40% with chemotherapy, and even a little bit more benefit from tamoxifen with about a 50% lowering in the risk of recurrence with the addition of hormonal therapy compared to radiation alone. We've also seen this very nicely demonstrated in patients receiving anti-HER2 therapy. This was the initial New England Journal joint analysis of the NSABP and the NCCTG, showing the impact of trastuzumab on overall survival. But they also went back and looked at the impact of trastuzumab on local recurrence. And what they saw was that in both trials, the chance of local recurrence was about half with effective anti-HER2 therapy. And we saw this in patients treated on the APT trial. This was Sarah Tolani's trial looking at adjuvant TH chemotherapy in women with early stage HER2 positive disease. And we saw that there were almost no local recurrences in patients who were treated with effective anti-HER2 therapy. So the second reason, in addition to more effective systemic therapy, is an improved understanding of the biologic diversity of breast cancer and varying rates of local recurrence and possibly sensitivity to radiation, although I think that's less well understood across the biologic subtypes. And this is an analysis from Mass General and Brigham and Women's Hospital showing that overall, the local recurrence rate at 5 years was about 2% in women with early stage breast cancer. But if you looked at patients specifically with approximations of luminal A disease, so those are patients with ER or PR positive, low or intermediate grade tumors, there was a fraction of a percent, so less than 1% risk of local recurrence, in contrast to patients with triple negative cancers. This is a very similar design to the CLGB and the PRIME2 study out of Canada. So Dr. Files did a phase 3 randomized trial, again looking at hormonal therapy plus radiation compared to hormonal therapy alone, but this time in women over 50. And in these relatively unselected patients, he showed very similar to the NSABP trial in tumors less than a centimeter, that the chance of local recurrence at 8 years was about 18% without radiation, decreased to 3% with radiation. So not good enough to omit radiation. But what was really interesting is that he went back and tried to approximate the subtype in a subset of patients where slides were and blocks were available. In the population of patients with luminal A approximations, so those were patients with ER, PR positive tumors that were HER2 negative with a low Ki-67 and without high-grade disease, there was no benefit to adjuvant radiation. And you can see that in the top graph here. In contrast to patients with either luminal B approximations, so those who had higher grade tumors, and then unfortunately all the rest were lumped together just due to small numbers, you could see that in these other subsets, there was a substantial benefit to radiation. Now, we also have really interesting data looking at molecular predictors of local recurrence. And I think the best studied is Oncotype. And while, of course, this was designed to study the benefit of chemotherapy in these patients based on molecular characterization, we also have some retrospective data showing the impact of Oncotype, or the association, I should say, of Oncotype on local recurrence. And probably the best data on this is from the NSABP, Dr. Mamounis. He looked at almost 900 patients with an available recurrence score culled from 2 prospective trials. NSABP B14 looking at tamoxifen versus placebo, and NSABP B21, which looked at tamoxifen alone or tamoxifen with chemotherapy. So 2 systemic therapy questions. But what he was able to find is that the risk of local recurrence was proportional to the recurrence score. So patients with low recurrence score had low chance of local regional recurrence, in contrast to the patients with high recurrence score, even though these patients were not randomized for a local therapy question. And we also have similar data looking at PAM50. So this is based on RNA extracted from paraffin-embedded blocks. And the assay measures the expression of 50 target genes and 8 housekeeping genes, which look at biologic aggressiveness and rapidity of reproduction. So they look back at the Australian breast and colorectal study group 8, and these were patients that were randomized to 2 years of tamoxifen versus 5 years of tamoxifen followed by, 5 years of tamoxifen versus 2 years of tamoxifen followed by anastrozole. And what they also found was that while not randomized for this question, local recurrence was proportional to the PAM50 score, and that in their low-risk group patients by PAM50, so by molecular analysis, the chance of recurrence was very low compared to the patients with a high recurrence score. And on multivariable analysis, PAM50 analysis, high versus low, had a greater hazard for recurrence than many of our traditional factors that we think of as being predictive of local recurrence. Node positivity, age, and treatment group. So given the relatively low rate of local recurrence in select patients, I think the question is now, can radiation be omitted? So this is predicated as on better systemic therapy and improved selection of patients based on improved understanding of the biologic heterogeneity and the biologic diversity of breast cancers. This is a look at the ongoing trials studying omission of radiation, and I'll just take you through these briefly. So the first 3 are small, fairly small prospective single-arm trials. All have completed accrual. IDEA is led by Reshma Jagsi at the University of Michigan, and this was a small 200-patient study of omission of radiation in patients with oncotype less than or equal to 18. Precision is a trial led by us at Dana-Farber. This is a multi-institutional trial within the United States, looking at 350 patients who have luminal A disease as defined by their PAM50 score. And Lumina is a Canadian trial, again, phase 2, but single arm, looking at grade 1 or grade 2 patients with a low Ki-67 score and omission of radiation. So all three of these have completed accrual, but are too early to report any mature results. Now, the two trials that will likely define this question are, excuse me, let me go back, are Expert from Australia and New Zealand. So this is a phase 3 randomized trial in women with low PAM50 scores. So everyone will get hormonal therapy. Half the patients will get radiation and half will not. And then just activated last week is Deborah, which is led by Julia White from Ohio State. And this is a multi-institutional trial from the NRG, which will randomize patients with an oncotype less than or equal to 18, ER or PR positive, node negative cancers in patients older than 18 will randomize to hormonal therapy alone versus hormonal therapy plus radiation. And I think the lower two randomized trials will really be practice changing, but fortunately, I'll be long retired by the time those report out mature results. So in conclusion, I think that patients younger than 65 with invasive disease should routinely receive some sort of radiation, be that partial breast or whole breast radiation, and that's really a talk for another time. In older patients, based on the CLGB and the prime 2 data, consider life expectancy, comorbidities, and the specifics of the pathology that unfortunately neither of those two trials were able to sort out: grade, LVI, margins. And then, of course, and not third in most importance, is patient preference and how patients feel about their risk of recurrence versus wanting a kind of do everything approach to give them the lowest possible chance of recurrence. And for younger patients, consider trial enrollment. My guess is that we will not be radiating many patients with stage 1 luminal A disease and possibly even HER2 positive disease receiving effective anti-HER2 therapy 10 years from now. So I'll stop there and thank you so much again for the kind invitation.
Dr. Sami, moderators. To talk about the advance in breast radiotherapy. So our talk